Thank you, Martin, for inviting me to this beautiful conference. I am impressed, and I agree with your wife that I can see how it would get out of hand. And I'd also like to thank a group that I'm working with, because I'm standing here, but I'm working with a group of quite inspired therapists and researchers. And if you see right now, Joost Hutsebout, I'd like to thank him especially because the presentation I'm giving today on clinical staging of borderline personality disorder and early intervention is work actually we've been doing quite together in the last few years. So it's just as much his as mine, what we're presenting. And these are all the people that are involved in the Netherlands in our research and the work we're doing. We started 12 years ago with mentalization-based treatment, and right now the Viersprong, the institute we work for, has 4 locations and 40 different MBT programs, treatment programs. So there's a whole bunch more of therapists that I don't have their pictures right now. And this is our research group right here. This is MBT Netherlands, and this is our research consortium with several professors that are involved in the research we're doing. So I'd like to thank the whole group for making possible what we're doing right now. And if I start right now, I'd like to start with the burden of disease in adolescence, and then specifically the burden of mental disease in adolescence. And if you look, DALYs are disability-adjusted life years. It's a measure that was developed by the World Health Organization to measure burden of disease throughout the lifespan. And here you see the lifespan. And these are the DALYs specifically for mental disease. And what you're seeing is that it's starting in pre-puberty and peaking in adolescence and young adulthood. So chronic mental disease is starting to show up in puberty and peaking in adolescence. So that's an important thing to remember in what I'm going to be presenting on early intervention. And this is another slide that kind of shows the same, in which it relates the burden of mental disease to the burden of other diseases. And here again, you're seeing that in the adolescence period and young adulthood, the burden of mental disease is a quite high percentage of the burden of total disease. So more reason to think about intervening earlier with younger people when they're starting to show these signs of mental disease. So we do see adolescence as a key period for intervention. And mental disorders, Thomas Insel is a famous neuroscientist and psychiatrist, and he was the director until last year of the National Institute of Mental Health. And he calls mental disorders the chronic disease of the future, so the chronic disease of the youth. And what you're seeing is that almost all mental disorders have their onset and their maximum impact in adolescence. And what you're also seeing is that past that risk period, there aren't that many people that are actually starting to develop mental disease. So most of it is starting to develop early stage. People are taking a long time to search for help. Here, research says it takes approximately 10 years from the onset of certain symptoms before people come and ask for help. And I read a very recent publication on psychosis, and what they even showed is that people with attachment problems, that they even take much longer to reach out for help. So the group of borderline personality disorder patients, which do have a lot of attachment issues, might even take longer than this 10 years before they seek help on their own. Early intervention and clinical staging. Early intervention is important, and clinical staging is kind of a strategy to work with this. And clinical staging has proven to be very effective in medical issues. So like with cancer, diabetes, heart disease, the medical staging and the early, which helps to detect early and to intervene early, has actually helped to drop the mortality rate by huge percentages. So if you would think about it, What is clinical staging? It's actually just a refined form of diagnosis in which you describe the stages progressively from stage 0 to stage 4, in which stage 4, stage 0, there's just a general vulnerability and there aren't really any symptoms yet. And then it moves on to in stage 1 where some mild symptoms are developing, and then going down to stage 3 where there's a full-blown mental disorder, and stage 4 where it's quite persistent and chronic. So in this clinical staging, they're trying to describe the progression of diseases from a very young age and the first vulnerabilities up to the full-blown disorder and the chronicity, right? And so when we were seeing this, in medicine, it's been used for quite a long time. And in the past few years, what we've seen is that it's quite kind of up and coming. Psychosis is working with clinical staging, and bipolar disorders are working with clinical staging. And we thought, why not with the borderline personality disorder? Why not work with the concept of clinical staging? To work with the clinical staging, there's actually 3 criteria that are important about a disease to be able to match in the clinical staging. And these are the 3 criteria. And we do feel that the borderline personality disorder would be a good candidate for this clinical staging, because it is a disease with borderline vulnerabilities, and then I mean the affective dysregulation, the impulsivity. We do feel with those vulnerabilities that you are more susceptible to negative life events, less viable to use your social support systems, etc. So the disease is a disease that can progress and can become quite chronic. That's the first one. We also see that the borderline personality disorder is capable of remission and to some degree is curable. 10 years ago, well, no, maybe now 15 years ago, it was thought that borderline personality disorder, that the patients would never get better, that you might as well just not treat them or see them every once in a while and then just hope it gets better with old age. And things have changed. It is at least partially curable. And the last part, there is some evidence that early intervention is helping and increasing the chances that the vulnerabilities won't progress into chronic, long-lasting diseases. So we thought borderline would be a good candidate for clinical staging. And if you think about it, I started working with adults. Now I work with adolescents. But when I worked with adults, if you think about the typical borderline patient, I would think about the 30-year-old female that cuts and burns, maybe is addicted to drugs, has no stable relationship, hasn't finished her schooling, isn't at work, et cetera, et cetera. That's kind of the typical average borderline patient that could present itself at 30 years. And isn't it kind of a normal thought to think of that as kind of an end stage and not a beginning stage, but just as an end stage of this whole continuum? So we tried, this is what a clinical staging model of borderline personality could look like. We're just kind of playing around here and trying to integrate different things from research. And the essence would be that it would start in pre-puberty with more general vulnerabilities, and then you would find the first markers that are more sensitive to and more already looking like the borderline symptoms. And then we're thinking of affective dysregulation, of impulsivity, and of self-destructive behavior. And it could then progress to the full-blown borderline personality disorder with also a progression in extra comorbidity and more impairment in social functioning. So this is kind of like what a model could look like. And if you want to work with the clinical staging model for the borderline personality disorder, there are certain assumptions that you make that fit with the clinical staging model. And the first one is that the progression towards the borderline personality disorder is not inevitable. And we know that it's not inevitable. Not everybody that presents with stage 1, 0 or 1 symptoms will progress to the full-blown personality disorder, borderline personality disorder. The other way around, though, the people with the full-blown borderline personality disorder, they have progressed. They have progressed from a general vulnerability and have their severity of their symptoms has increased, and also the severity of the impact on their social and vocational functioning. So it does go one way, but not the other way necessarily. We also know, that's another assumption in a clinical staging model, that the development can be changed, that it can be stopped, and it can even be reversed. And we do have evidence from different kinds of, I'm going to be talking about mentalization interventions, that this can be done, that you can stop the progression and even reverse the progression. So those are important assumptions about the progression of the disorder. Other assumptions are that the earlier you intervene, the more effective and the more benign the interventions might be. And benign in what sense? Benign in the sense that because they're often not quite as intensive, because they're often more simple, that they have less of an impact on normal development, and they might also be less stigmatizing and more effective. So the earlier the intervention, probably the more effective and also cost-effective it would be. And what the clinical staging is working towards, it's not for a stepped care. Because what they want in a clinical staging, what you're trying to do is to do a stage-appropriate matched care. So if somebody presents with a full-blown borderline personality disorder and you're using the clinical staging model, you would give another intervention than if somebody presented with a stage 1 borderline personality disorder. So this is not for stepped care, but for matched care and for stage-specific and matched care. Another assumption is that the interventions aren't only specified to the stage that someone presents in, but also specified to the developmental needs of the individual, of the younger patient. So a 14-year-old presenting with a beginning borderline symptoms, the intervention might be different than from a 19-year-old presenting with borderline symptoms. You might have more intensive family treatment depending on if they're still living at home. And so you need to look at these developmental needs, not only the staging. And the last one is that another assumption with the clinical staging is that it should be structured in a service model in which the therapists aren't just focusing on one episode, but they're mindful of the fact that this is an illness and there are risks for progression. So it would be nice if the service working with this clinical staging model would offer the possibility for intermittent care, for people to come back when and if necessary. So the follow-up, so the evaluations and the follow-up are planned according to the stage. And so people in later stages, you might have a longer follow-up period than people presenting in earlier stages. So those are the assumptions of a clinical staging model if you would work with this for the borderline personality disorder. But there's also a lot of challenges and implications. And the challenge in the early detection is, especially in the stage 0 and the stage 1, is how are you going to differentiate between stage 1 borderline personality disorder and a distressful period in normal development? That's not always easy. So, and we do the most sensitive markers that we have right now that we know from different studies is the affect dysregulation, the impulsivity, and self-destructive behavior. We know those are the most sensitive markers, but we need more markers. We need more research to find certain biological, social, and psychological risk factors, and also protective factors. So we need a lot more information. The model we present, I mean, it might look like that, but I think it needs a lot more refinement, and we're not quite there yet. And we also feel it's important that to try to avoid vague diagnosis for youngsters that are presenting themselves with subthreshold disorders. Because we're afraid that people aren't getting the right interventions if you just are too worried about the stigmatization and not diagnosing. We're worried they're not getting the interventions. And when working with a clinical staging model, it's not as stigmatizing to say something like that they're in this possible development, and luckily they're in really early, and we can treat this together before it impacts on all kinds of other phases of life. So it's actually a quite friendly way of also speaking with the clients, patients. Another implication and another challenge is that we don't have a lot of evidence-based interventions, preventive interventions. There are some, but not that many. Right now there's a program in Melbourne, it's called Headspace, and they're working with they have actually several service centers that are very easily accessible for youth. And they in a quite playful manner, lower anyway, make it easier for these people to come in. And they are treating patients with early stage developmental mental disorders this way. So that's an example of a place where they're quite ahead in this sense. At the Veersprong where we work, we started with quite of a classical way of assigning someone to a treatment program. It was based on diagnosis, but it was also based mainly on age and what we had for that age category. And we are evolving because we've learned that we have several programs. So we have the MBTI introductory course, we have it for the adolescents, we have the MBTI introductory course adjusted for parents. We have MBT early, which I'm going to talk about in a minute. We have the MBTA. It's a different one than Trudy has. It's a more intensive form of treatment. So we have different programs, and we are evolving now and trying to match more to the clinical stage, because sometimes we would have like a 14-year-old that because of age we thought would belong to MBT early, but they were presenting actually with already stage 3 or 4 symptoms, full-blown borderline personality disorders, and already not going to school, and being taken out of the home, and so already also quite impacting on different levels. And the MBT early program we had wasn't enough. But likewise, we would have older patients for which the intensive program was too much. So we're evolving and now trying to assign people to different treatments according to the stages we think they're in. And I'd like to present quickly 2 of our new ones where we have pilot data. I mean, it's pilot data, so, but I'd like to present them. And the first one I'd like to present is about the mentalization-based treatment early, MBT early. We call it that because it's an early intervention program, and it was designed for stage 1 and stage 2. So it's designed, if you look at the criteria, for subclinical borderline PD. 3 to 4 traits, or a full-blown PD, but then that just had an onset right then. So a recent onset. So this is the group that we designed MBT early for. So they are having problems, and if you see that here, it is a group that is having significant problems, because you can see here that 53% did have a borderline personality disorder. 75% also had another personality disorder as diagnosed by the SCIT. And they are presenting on behavioral and emotional problems at clinical or subclinical level. So it is a group that has problems. They're not quite as severe as the full-blown borderline problems that I'm going to show in a minute, but it is a group that is having severe issues. And also the personality adaptation you're seeing is not quite strong. They're having problems in their self-control, in their identity integration, in their responsibility, and all these issues. They're showing already impairments. The features of MBT early. MBT early is a mentalization-based treatment, and we integrated elements from HYPE-CAT, so from Help Young People Early from Andrew Chanin, and we integrated issues from the dynamic interpersonal therapy into this mentalization-based treatment program. It's highly structured, 16 manualized sessions and a booster period. It integrates individual therapy, it integrates family therapy, it has some case management and pharmacotherapy. And what we're doing is, like in England with the POD, a weekly routine outcome monitoring. Right here, standard, we're doing the generalized anxiety disorder, the GAD, and the PHQ, the measuring depression. So those we're doing every single session. And then according to the goals, which I'll speak of in a minute, we might add 1 or 2 lists so that every session the patient comes in and first fills in these questionnaires. Obviously, what we're trying to do is to prevent the progression to a later stage of the borderline personality disorder, to facilitate the healthy development, and to empower the people and their parents. So the attitude is, at the end of these 16 sessions, it's going to be the beginning of the change. You're not going to be completely well. All the symptoms won't be gone, but a change will have begun, and we hope you'll have enough tools and be able to work on this with your family and, when necessary, with us to go on with your development. So you offer as much care as possible, but as little as needed. The other way around. So here's the format of the MBT early that we're working with. We had a slightly different format, and it changed about a year ago, and this is the format that we have the new data on. And these are the 16 weeks, so it's 4 months, no longer. And in those 16 weeks, we have 1 psychoeducation session, 16 weekly individual sessions, 2 family sessions, and 2 treatment review sessions. And throughout the whole phase, and the whole phase with the booster takes about 9 to 12 months. Throughout the whole phase, we have case management, psychiatric management, and telephone and email consultation. This is the main phase, what we do. The first 3 sessions are basically assessment. So their assessment, the main assessment is about what are the 2 major problems the young people, the young person wants to work on. What problems do they think, if they work on that, will make the difference for them? So that's part of the assessment. When there is self-destructive behavior, we do a mentalizing functional analysis of the self-destructive behavior and crisis planning. That might be a session. And we do assessment of the relationships they have. So the peer group relationships, family relationships they have. And all together with that, at the end, together with the patient, a treatment plan is made with 2 goals. That's it, 2 goals. And then after that, 10 sessions, they work on the 2 goals. So the goal could be to feel less depressed, and another goal could be to minimize the aggressive outbursts. Those could be 2 goals, for example. And what you do then is every session, you have the routine outcome monitoring. So when they come in, you already know what they're reporting, if it's going better or not going as well or whatever. And then you enhance in the session their mentalizing around these goals. So like if the issue is depression, you enhance their mentalizing, okay, so how were you feeling this week? And what do you think were important issues that might have affected you this week? And how did it affect your relations? And how is that affecting you again? So you're mentalizing about self, others, and relations with a focus on these 2 goals. 10 sessions. Then at the end, the therapist writes an end letter. These are tough to write, but the patients do really appreciate them, in which you as a therapist are quite transparent about how you see the patient, how you see how he or she presented, what the problems were, what you think were the things that helped in therapy, what you think are their protective factors, and what you think they might need to be alert about in the coming period of time. So you write a letter with your ideas about these issues. And in the last 3 sessions, you talk about this letter, and you also together make a relapse prevention plan. And these relapse prevention plans, they're quite based on mental states. So it's not, they're not behavioral relapse prevention plans. They're based on mental states that could lead to depression. So moments when I'm feeling lonely and I'm feeling excluded from the group are moments that I need to be alert and do whatever. So that's the main part, 10 sessions. With 3 assessment and 3 end sessions. So that's 16 sessions in 4 months. We do it weekly. Then after that, they have a booster period, which takes 6 months. And in these 6 months, they have 4 sessions, individual sessions, and a family session. So it's not a lot. But in those sessions, you're promoting actually their treatment independency and using this relapse prevention plan. So you're seeing how did they do in that last period? How did they do and what were helpful things? And if things didn't go so well, did they use the plan? And what were things that were helpful and what might we be missing in this plan? So you basically, again, focused on the 2 goals and on the relapse prevention plan and used that as follow-up in these booster sessions. And then at the end, the last session was with the family. And at that point, you kind of evaluate the whole treatment about what has helped, what hasn't helped, what is the status quo right now, is the younger person still presenting with problems in a clinical range, or are they more in a normal range? And do the parents and the younger person feel capable enough of dealing with these issues? So that's basically what we do the last one. And the most important part also is when should the parents or the younger person be worried, and when can they just keep going on the way they are? So you talk together about signals to be alert for. So that's it. And these data, I mean, it's almost embarrassing to present because these are the first 19 patients. We didn't have the routine outcome monitoring of the CBCL and the other one that I showed you in the beginning, but we did have the data on what we did weekly in the session. We did have that data. So on the PHQ and the GAD, we had the data of these, how many patients? 28 patients. And so this is measuring depression, and what you're seeing is that on average they're going from moderate to severe to mild. And with anxiety, you're seeing the same thing, from moderate to severe anxiety states to mild anxiety states. And this is in the first 16 weeks. This is all we have right now. So it's just a start. It's a hopeful start for this group. We didn't have any dropouts. We did have 1 patient we had to refer to MBTA, which I'm going to talk about in a moment. But of the 28, so 1 person we referred, and the other 27 completed this treatment and are now on their own. We don't have data yet about what happens in the next years. We do have an evaluation and a follow-up planned, so we don't know that yet. But all we know basically now is that these first 16 weeks, because that's what we measured here, that they are having an impact. And if you look at the qualitative analysis about how they felt about it, they were also quite satisfied with the treatment program. The parents and the patients were quite satisfied. basically, they all said that it helped. And in the group patients, they said, none of them said that they still had significant problems. The parents didn't quite agree, but the difference isn't that big. The biggest difference is with the treatment length, if it was okay or not. The parents felt that the treatment length was okay, and the young group only, the young patients, only half of them felt that it was okay. And so I was kind of curious, are they going to say it's too short or it's too long? It's exactly half-half. So half of them said that it was right, half of them said that it was too short of the other half, and half of the other half said that it was too long. So, okay. And most of them found the booster period also useful. So this is the qualitative, and I think it's quite promising, but it's still very preliminary. Then if we go on to our next program, that's the mentalization-based treatment for adolescents. And it's different from Trudy Rosau's because Trudy Rosau had a wider range. I think if we would clinically stage the patients she had, they would be from stage 1 to stage 4. I think she had a little bit of everything in it. And they had individual sessions weekly and family sessions once a month. And we based our mentalization-based treatment program for adolescents on the intensive outpatient program that the adults have, the evidence-based version that Peter Fonagy and Anthony Bateman published about. So the program is more intensive than Trudy's program, but we also only have it for the more severe patients. They all have a full syndrome of borderline personality disorder, and it's had, with all the patients, a severe impact on their social and on their, I don't know if you call it vocational or professional, anyway, their schooling functioning. So in our staging model, it would definitely be stage 3 and stage 4 presentation that we were admitting, that we were allowing to follow this program. Right now, I'm in one of those groups, 9 patients, 8 girls, 1 boy. One of them lives at home. The rest of them either come from a forensic youth institution or from shelter, or are in some form of sheltered living. When they came in, one was still attending school, the others weren't attending school. So it was a quite severe group in the sense of the impact that their vulnerabilities had on their functioning. All of them had comorbid disorders, so it was a quite severe, or it is a quite severe group we're trying to treat here. The structure of the program you see is more intensive and it's longer. The pre-treatment already takes 3 months, and in the pre-treatment, everybody has the MBT introduction course. The adolescents have their, it's basically the same as the adult MBT introduction, but we added 4 specific adolescent themes, and we changed, we made it more adolescent specific, the first 12 that are also in the manual. They also, all parents did MBTI introduction in a group for the parents. That's only 3 sessions of 2.5 hours. So that was in the beginning. Almost everybody had destructive behavior. So in that sense, in the pre-treatment phase, we did the mentalizing functional analysis of this destructive behavior and crisis planning, and started with the treatment planning. So that takes about 12 weeks because the MBTI takes 12 weeks. So, but if there's a place earlier in the group, they can go in earlier. And sometimes they have to wait, and then they just stay in the group and do it again, the MBT introduction course. So that's the way the pre-treatment phase is. Then comes the main phase, which takes a maximum of a year. The average treatment is about 10 months, but it's a maximum of a year. And they have weekly group therapy, 1 time a week, and they have weekly individual therapy, and once every 2-week family therapy. It's based on MBTF, but it's a year-long family therapy. And of course, they have their psychiatric consults and the case management, because there's a lot of case management to be done, trying to get everybody coordinated. So also the people, we go actively to the schools where we try to get them to go back to. We have active contacts with, so we work very outreaching with the sheltered living. And depending kind of on the home situation, it might be with a goal to move them back towards home, but it also might be with the goal to have them living independently. So it depends, but there's also a lot of case management going on. And the focus is the same focus as also in the adult MBTA programs. It's enhancing the commitment to treatment, it's working on the psychiatric symptoms, it's lessening the self-destructive behavior, and improving their interpersonal relationships, and also improving their social and societal functioning. So those are 5 basic goals that we have in all the MBT programs, and then they're individualized, of course, according to the person and the certain themes that are with this person. And then the post-treatment, sometimes they're finished and they have a maximum of 18 months, and that is step down individual, in which basically they're mentalizing maintenance sessions. So they, it usually has a focus on them going back to school, because they are back at school, and the focus is on maintaining the gains they've had in their mentalizing capacity. So this is the structure. It's actually quite similar to the IOP for the adult program. And this is, this is being taped. This should be taped. Because this is of the first 19 patients and we had a hard time getting the data in. We didn't have the money, we didn't have the research assistance, so we only had the routine outcome monitoring. We had a hard time getting the data. Right now we do have all of that, so I hope within a year or 2 years to be able to present more data. But what you are seeing is there's a big difference in symptom distress, in their self-control, and in the responsibility. We're seeing big differences in those areas. And if I look at the group, that I have right now, I would say that 75% of them are back at school. We have a low dropout rate. The dropout rate is 12%, which is also kind of equal to the adult program. 75% is back at school, and a large percentage of them are either living, more than half are living either independently or are back with their parents. And I think it's like 35% that are still living in the sheltered living or in the forensic institution. So we're seeing improvement in their social and their vocational functioning. And basically what I'm hoping to conclude is that early detection and early intervention is really important, and it's feasible for the borderline personality disorder. We think that the clinical staging model is a feasible model to work with. It does need a lot of work. We think that interventions should be tailored not only to the stage that the people are presenting themselves in, but also to the developmental needs. And we gave an example of the 2 programs that we're working on right now, developing, and we have research going. And I'd like to conclude with this sheet. Thomas Insel, that I talked about earlier from the National Institute of Mental Health, he presents this sheet in his TED Talk. It's a great TED Talk if anybody's interested about the clinical staging. And this is the last 15 years. And if you see, in the last 15 years, stroke, AIDS, heart disease, ALL for leukemia, how tremendously the mortality has decreased. In the States, like with heart disease, 1.1 million people less are dying because of heart disease. Anyway, so these are numbers for these medical conditions. And basically what he states is that early detection or prevention, early detection and early intervening have helped the significant, huge reduction in mortality. And my point that I'm trying to make is, wouldn't it be really terrific if 15 years after now, we would have more markers. We would know more early signs. We would have more risk factors, protective factors. We would have more evidence-based early intervention programs, and that we could also say there's 25% less full-blown BPD patients. Thank you.